Understand, again, I talked about diluent curves. When you're reconstituting, the average number is 2 to 2.5 units. I use a 2 millimeter reconstitution with diluent of normal saline, and that gives me 5 units per tenth of a mil and 10 units per 2/10 of an ml, and we're very used to and comfortable with that kind of dosing. There is certainly nothing wrong with higher or lower volumes of reconstituted Botox in terms of the amount of diluent that's placed. I think everybody has to have a comfort level. What's important about it is how many units that you're delivering to the treatment area. That's what we all know. It doesn't matter how much volume is delivered, it matters how much product is delivered. What we also know, however, is that the higher the volume, the greater the regional effect of or the spread effect, if you will, of the product. So one has to keep that in mind. Injecting 10 cc's in the glabellar area, even if it's only 20 units, might have a greater diffusion effect than injecting, 0.5 or 0.2 cc's. So very important to keep that in mind. At a 2.5 to 1 ratio of Dysport units to Botox units, there are a couple options in mind. If you're using 2 ml of Botox and you want about the same treatment amount, in other words, the same treatment therapeutic effect, and you use 2.4 ml of reconstituted saline, you'd really be using the same volume per treatment area as you were using for Botox. What we found is the characteristic of Dysport is that there is slightly greater regional effect, spread effect if you will. I don't know if the right term is diffusion, which has a specific name, but it's more spread effect, more regional effect, and we can use that to our advantage by making it slightly more concentrated. So I use the 1.5 ml reconstitution, much like we did in the clinical trials, and that gives me about 20 units of Dysport per 0.1 ml. 25 per 0.125, and that's important. This number is important because this is a single site treatment area, and 0.25 ml would give us 50 units of Dysport. And I think those two numbers, the 25 and 50, are important if you're sort of using those as your therapeutic targets. As it relates to the FDA, I think that their guidance documents were right on. One thing that we're going to have to do, these products, once they're reconstituted, look like clear solution. I would suggest that everybody use potentially a different syringe or label each syringe if you have both products in your office so that you're not confusing a Dysport syringe from a Botox syringe. In our practice, I've decided to use the 0.5 ml BD syringes that are insulin syringes. The number of units shown on the barrel of this syringe are insulin units. They don't have anything to do with Botox or Dysport. And I'm using the 0.3 ml syringe for Dysport. So with Dysport, I'm using the 0.3 ml syringes, and you can see with our reconstitution strategy, I put 1.5 ml in the vial. We'll pull up 0.125 ml here, which if you look at it, it really is equivalent to 12.5 insulin units. I know that that's 25 units of Dysport. So in these types of 0.3 syringes, if I pull it up to with our reconstitution at 1.5, if I pull this up to 0.125 or 12.5 insulin units, I know that there's 25 Dysport units. And in the larger syringe you see here, if I pull this up to 25 insulin units, I know that there are 50 Dysport units. Obviously that changes if the amount of diluent you put in to your bottle, a vial, is different. With Botox, using the 2 cc reconstitution diluent volume, these larger syringes, if I pull up to 20 here on these syringes, I know that there's going to be 10 units of Botox. 20 insulin units is 10 units of Botox. If I pull up to 40, that means that's going to be 20 units of Botox. So what's interesting about it, and again, the main thing about this is these syringes are different and the volumes are different. So I know if I walk into a room, I can tell what is a Dysport syringe and what is an insulin syringe. And I think if you're going to have both products in your office, you need to figure this out. You either need to have the syringes labeled or you need to have different syringes and have this figured out. Again, it's simple for us here. With the insulin, with the 0.5 insulin syringes, there's exactly half the number of insulin units is the number of Botox units. So again, pull it up to 40, there's 20 units of Botox. Pull it up to 20, there's 10. With the Dysport, it's exactly twice the number of units. So I pull it up to 12.5, it's 25. I pull it up to 25, that's 50 Dysport units. So it doesn't matter how you do this, but I think it's very important that you think it through in your office when you're implementing the treatments with these products. Now in our office, again, if you have both of them, we'll have boxes labeled. They'll be mixed up in advance. We're not running around with each patient trying to do this, obviously. One box is labeled with Dysport, one Botox Cosmetic. We will have the syringes placed with a little cooling pack in there ready for use, and we'll have them available on a day-to-day basis, cooled and refrigerated. And I just think it's important to keep these managed and separate. Now, we've talked a lot about reconstitution with the current products. We've talked about the different ones that may be available in the future. Let's get to some specifics on therapy. There are obviously a multitude of functional anesthetic therapies. We're going to focus more on the functional therapies today and talk a little bit about facial paralysis for those of us that are facial plastic surgeons. But I will tell you in areas like hyperhidrosis, blepharospasm, that these things are wonderful, and potentially even headaches. These can be wonderful therapies and shouldn't be ignored. The aesthetic indications include the entire face now, I mean face and neck, so we're going to get into those in some detail. This paper published in the late 90s and presented in the early 90s on its application for facial paralysis shows that if we treat patients on the contralateral and ipsilateral side, that we can really relax some of this synkinesis. This is a patient who had a right-sided facial paresis and has now residual synkinesis after recovery. Using a botulinum toxin, again, this would be about 25 units of Dysport, or in this patient treated with Botox, about 10 units of Botox. We can really get a nice improvement in this synkinesis for the patient. We can even improve some of the symmetry and dimpling of the chin that's commonly seen in these types of patients. I use typically 5 units of Botox, and that would be the equivalent of about 12.5 of Dysport in this area here to smooth that dimpling effect out. And you can see even improvement in the nasolabial fold by very light doses treating the zygomaticus major muscle, which obviously helps this lady. With more severe patients that have really the problem of distortion from severe contralateral pull, treating the zygomaticus very conservatively, 5 to 10 units initially at tops for Botox to reduce the non-volitional severity of her smile, and then ipsilaterally on the area where she's got synkinesis and eye closure with smiling, can really improve her overall appearance, especially when she's doing non-volitional smiling. And this is particularly embarrassing to the patient with facial paralysis. Now, we did some work and published a paper in the late 90s looking at this, and this paper was really generated as a result of a lot of confusion about Botox, Cosmetic, and the anatomy. There were early speakers, and I still have some on video, speaking about injecting the wrinkle specifically with Botox as though it was a filler. And obviously we all know now that we're treating the muscular anatomy of the face and not treating the surface anatomy. What's really surprising, however, is that many of the anatomic diagrams that are out there now are really incorrect, and I think they just get perpetuated from one incorrect drawing or schematic ideal to the next artist drawing them. And so the purpose of this paper was really to explore the position and depth of the muscles in different areas of the face, and with specific attention to the upper face. So this has been published. We've talked about this before, but we took 50 hemicadaver brows. We looked at both men and women. We made specific cuts at fixed anatomic places, mid-pupillary line, mid-canthal line, lateral canthus, and we measured the depth of the muscle from the skin surface. Here you see the frontalis muscle overlying the corrugator muscle in this patient, and we used calipers to measure those things. Once we had the depths measured, we actually measured the thickness at these various anatomic points, and what one can see is that in men and women there are some differences. Mainly the skin thickness is considerably thicker in men than women, as most of us would expect, and that the muscle of the corrugator is absent in the midline and absent at the lateral canthus. So the bulk of the muscle is really from the medial canthus to the mid-pupillary area. And these cross-sections show exactly what I was talking about. Here is the corrugator muscle at the medial canthal area. By the mid-pupillary area, it's completely attenuated, and this is reflected in this bar graph where you can see nothing in the midline. This would only be procerus. No corrugator lives there. And the lateral canthus, there's nothing there either. Now again, I see pictures like this in the textbooks, and this is not to pick anyone specifically out, but the corrugator doesn't sweep upward into the brow like this, at least in very, very few patients. As we know, the lines that are created in the face are perpendicular to the action of the muscle. If the muscle was actually diagonally placed like this, most of the lines we would see in the glabellar region would be at a 45-degree angle. They wouldn't be vertical. So again, I think a lot of these things get perpetuated. And I think they are very schematic and nice looking, but that doesn't make them anatomically correct. There are, again, a handful of patients that might have that type of appearance, that phenotype, if you will, but those patients are few and far between. Most people have the 11's lines between the brow, and thus the treatment should be directed really at the club head of the brow and at the mid-pupillary line, just slightly at or slightly above the brow hairs, not up here in the middle of the forehead where you see many of the diagrams, including the package inserts that come from these companies, if we want to target the corrugator muscle specifically. This is probably the best anatomic drawing I've seen that's schematic, where you actually see it tracing along the brow and parallel to it, not higher, just slightly higher than the brow position. And again, treatment strategies, we're going to show videos here, but I think grabbing the club head of the brow and traveling with your needle parallel to the muscle is the best way to assure that you're going to get the maximum delivery of product to the muscle. I've seen the come straight at you technique, and that's fine, but of course you're not delivering along the length of the muscle, so there's probably less of the neuromodulator being delivered to the area of treatment, and we'll get into some detail with this later. Everybody's seen glabellar results here, and I think you can see a before and after pictures. We'll show more of those in just a moment. Now, the glabellar area is the primary area where we see this complication of eyelid ptosis. Eyelid ptosis is manifested by ipsilateral brow elevation, sinking of the eyelid margin where there's partial coverage of the pupil, and in many patients actually there is sort of a subclinical acquired or congenital eyelid ptosis that can be unmasked by treating the forehead area. So I think people should be aware of making this diagnosis in advance of the patient anyway. The condition is caused, in theory, by diffusion of Botox, and again, I have a hard time believing that diffusion of Botox from the glabellar area subcutaneously through the skin, over the top of the skin to the and through the orbital septum and to the levator muscle is the primary or chief cause of this problem. Many patients are being treated right directly in the lid for blepharospasm, and if we were thinking that diffusion was the cause of this, it would be much more likely that patients treated for blepharospasm in this area would be seeing eyelid ptosis. I think it's far more likely that there's an anatomic explanation for this, namely that the supraorbital and supratrochlear foramina, which are right above the brow or in the brow region, as many of us know these neurovascular bundles come out here, are sometimes the sheath of the nerve or just the foramen itself is sometimes penetrated by the needle. And with a little bit of hydrostatic pressure, there's egress of the product, of the few molecules of botulinum neuromodulator, along this sheath in the foramen, and as it comes back into the orbit, it's simply a fissure. And you can see that the top muscle on this area is the levator muscle. It's the easiest one to affect and may actually explain why just a few molecules could cause eyelid ptosis, number one, and number two, when we get eyelid ptosis, it doesn't last as long as the whole therapeutic treatment, usually a couple weeks or longer. No one's proven the mechanism of action of eyelid ptosis. This has not been proven by me, but I really have a very strong feeling that it goes beyond just this issue of simple diffusion over the lid, or we'd see it much more frequently when treating strabismus. Nonetheless, when we see it, there are treatments for it. These are treating with alpha adrenergic agents, agents that actually help to lift the eyelid by stimulating Mueller's muscle, which is a sympathomimetic muscle. Iopidine is the main one. It's very difficult to find in from some pharmacies. Neosynephrine is more common, 2.5%. 1 to 2 drops 3 times daily until the ptosis resolves is the usual treatment therapy for that, and we encourage people to consider doing that. Keep in mind that there is going to be eye dryness, and these products do not last a long time, so they're only sort of a splint to get patients through the time when the eyelid's ptosis is most severe. Let's talk about the procerus. What's interesting anatomically about the procerus is that its length is statistically different in women than it is in men. It's obviously a stronger muscle. The yellow bar in this graph shows the length in women. up to 19 millimeters, where in men it's closer to 16, and this may explain why many more women complain of the horizontal line across the base of their nose than do men. Treatment in that area is usually in the range of 3 to 5 units of Botox and is directly related typically to treatment of the so-called bunny lines that are caused by the nasalis muscle. Again, 3 to 5 units in this area of Botox, that would be 12.5 or so units of Dysport are kind of ideal treatments for this region. So, the dosage summaries in these areas are very interesting. As we move further into this treatment strategy, I will say that we will be talking a lot more about Dysport units and Botox units for each of these areas. I'm going to give you a summary slide at the end, which would be the take-home message, at least for the upper face, in terms of what we're using for these areas. Now, with the frontalis muscle, it's very interesting. There's really two phenotypes. There's the so-called McDonald's arch type phenotype, and then there's the straight horizontal line phenotype. The people with the McDonald's arch have a significant diathesis in the midline, and as a result of that, it's not going to help you to treat these patients in the midline, as they don't have much muscle here. Their active muscle is laterally, these patients straight across the brow. In practice, for us, the treatment strategy is really identical for both groups of patients. The frontalis muscle from our studies is uniformly across in terms of thickness across the brow, slightly thicker, as you can see from the red graph bar, in men than it is in women. And what I will say about this, and you can see this in the diagram, our early strategies in treating the frontalis were, let's treat it like a scar. If we can knock out the line or break up the line in the middle, it'll make the line less noticeable. Of course, we all know now that that gives us a terrible result, because you get medial brow ptosis and lateral brow elevation, resulting in the so-called Mephisto look for patients. So, and this is data from the National Education faculty, and I've seen a lot of treatment strategies. This is not endorsed by the Allergan company, it's one of their slides, but this is a specific doctor whose treatment strategy was to just saturate the middle portion of the forehead with Botox. And again, I think that those kinds of strategies will typically result in brow ptosis medially, and I'll show you a picture of that in a moment. And then you have other patients who are completely akinetic in the forehead and have this medial brow ptosis, and while they can be quite attractive, I do not think this is a natural look that most people would feel fond of. As I said before, even when done carefully, we can pick up the medial frontalis muscle. I've seen pictures like this patient demonstrated in both textbooks and photographs of experts describing how beautifully arched they've done the brow. Well, the problem with this beautifully arched brow is I've arched it by dropping down the middle part of the brow. If you do a stick figure of this, you'll see that the patient looks angry. You can draw a simple stick figure, draw a brow in there that goes diagonally like this, and the patient looks angry. You also see medial hooding of the eyelid. So while shaping the brow, I think, is a phenomenal idea, and there's certainly ways of elevating the brow by treating the orbicularis, this issue of treating in the immediate suprabrow region, calling it the corrugator, when it's really the frontalis, results in this medial brow ptosis, and in my opinion is a very clear sign of the Botoxed look. So in terms of treatment strategies for us for the forehead, and we'll get into the orbicularis in a moment, forehead, I like nice even distributions, 2.5 units per site. Botox, it would be slightly higher in the 4 unit per site with Dysport coming along, 6 unit per site of Dysport, and coming along here in nice even distributions. If they have a high forehead, I'll come up and do a couple injection units, all symmetrically placed, all equivalent dosages, so we'd have good symmetry. Corrugator muscle, similar, and we'll talk about, I'm going to get into these dosage summary slides in just a minute, but this is published data for using the botulinum toxins in the region. And certainly with moderate dosing, we can efface these deep crevices in the forehead, before and after picture of a patient who clearly got a benefit without substantial brow ptosis as a result. Now this is the result. This patient, you see this adynamic mid-forehead and lateral elevation. She looks Botox. So this is again where we're treating maybe corrugator, got up a little too high here in the superbrow region, dropped her medial brow, got this regional effect here, and left the lateral brow untouched. And of course, this looks ridiculous. This Mephisto effect, the Jack Nicholson look, as I like to call it, can be treated with a two unit, roughly a unit of 2.5 units of Botox, and 4, 5 to 6 units of Dysport can be used to treat that area to drop that back down. Now, what about the crow's feet? Probably the best single indication for the botulinum neuromodulators, BOTOX and Dysport, that we have. This is an area where we can get both brow elevation and effacement of the lines. The one area that we can't treat are the lines that are a result of the smile elevation. When patients elevate or activate their zygomaticus major or minor, then move that cheek tissue up, they will get some lines there. But as you treat this lateral area, you can get both relaxation of the greatest depressor of the brow, as well as effacement of the fine periorbital lines, the squinting lines that we're all familiar with. There's a lot of discussion about placement of injection here. Immediately subcutaneously. The orbicularis muscle is immediately adjacent to the skin. This is not an intradermal injection. It is not a deep injection. It is an immediate sub-Q injection. It looks like you're lifting up a little wheel like you might with a tuberculin syringe, but it's not intradermal. It's immediately subdermal. So we can see that this muscle is a very superficial muscle. It's a very powerful, the lateral portions are very powerful brow depressors, and we're using that relaxation of that powerful brow depressor to help to elevate the eyebrow. This is a very important picture because this is a patient who's been treated on one side in the corrugator and the orbicularis and not treated on the other side, and you can see the powerful brow depressing effects of these two muscles in the untreated side. So if we're able to relax this side, you can see the significant amount of brow elevation that might be achieved by reducing the activity of those significant brow depressors. The pharmacologic brow lift, I described this some number of years ago, early 90s, mid-90s, published at about 2000. What we really proved in that study was that in patients that were treated in the entire periorbicularis oculi area, deactivating the brow depressor, we can get substantial brow elevation. In fact, what we showed was up to 5 millimeters of brow elevation, which is very similar to that we see doing endoscopic or even coronal brow lifting techniques. These were standardized. The patients were measured in a blinded way beforehand from the corner of the eye to the lowest brow hair at fixed points, lateral canthus and mid-pupillary line. They were treated and then they came back and were remeasured after a 2-week window. And this has been published and is available, but it's really showed a statistically significant elevation of the eyebrow. Now, what we also demonstrated was that we were treating this entire region, not just a little single drop by the brow. And while I have seen some good results with a single point treatment, anecdotally, there have been no studies to demonstrate brow elevation by doing a single point injection in one of these areas. Here are some patient examples of brow elevation. And of course, it's always hard to tell with these photographs of the brow because you never know if patients are really lifting their brow in the after picture. One good evidence, here's a good example of a patient who has deeper lines in her forehead than she does in the before than after, but you can see significant brow elevation here with shallower lines, meaning she's not activating the frontalis, and a good example of the kind of brow elevation that we might expect. Getting into the lower face, I think that the key areas where we really can see improvement are with these deep platysmal bands. The mentalis muscle are certainly good areas. Perioral lines can be treated, but I've found that it's highly variable, the results. You can't use high doses because it makes them have lip dysfunction. Small doses are fine, but you can't really see a big difference with small doses. Probably used in combination with injectable fillers, Botox in the perioral area is a good indication and treatment. Certainly the mentalis, the DAO has been described. We'll talk a little bit about that. But the one I think that's the greatest target in the lower face is, of course, the aging neck area. So the treatment of platysma bands for us is to grab really at the cervicomental angle and inject really the 10 units of Botox per band or 25 units of Dysport per band directly into the muscle and focusing it really right here at the cervicomental angle. And I do that consistently. I'm not so worried about lateral bands, but you can get very nice results in attenuating these bands. Here's a before and after treatment showing a lady grimacing with these deeper bands and a significant improvement in that banding, which can really reduce the cervicomental angle, even affect the results of a facelift. So very important to do that. Now, the oral commissure is a whole nother discussion. This angle gets deeper as we age. It becomes a groove in this area. There have been a lot of discussions and publications showing treating the DAO, the depressor anguli oris here, right down by the jawline is the best place to do that so you don't pick up any of the depressor labii. I can tell you that in my opinion, the results are highly variable. This area is better treated with fillers. However, there's no harm in trying 5 units per side of Botox, 12.5 of Dysport per side in a single injection site right at the angle of the jaw, somewhere near the oral commissure as sort of the target area. Probably the reasons for that are it's not just the DAO that's causing this depressed area. There's also soft tissue ptosis causing this area, loss of volume in this area, and to some extent muscular action. And also the variability of the anatomy in here makes the results inconsistent. I have seen very good published and other results using treatments with the DAO, so presumably in isolation, but I do think it's, again, the best thing for a combination therapy to treat the DAO right at the jawline, at the lateral commissure, dosing with about 5 units per side for Botox, 12.5 per side for Dysport. Very important, this is sort of the take-home message slides. Everybody wants to know about 2 things. Reconstitution and use and storage of these 2 products now, the ones that are currently available to us, Botox and Dysport, and then how do you dose them? What are your therapeutic strategies? So for Botox, and this has been published, this is the first slide, I'm typically using in the glabellar area 7.5 units at the club head of the brow and about 2.5 at the tail of the brow, which picks up Orbicularis oculi as well as the corrugator muscle. So I'll use that on each side. That'll completely deactivate it. If we're treating Procerus, I'll use 3 units or so, maybe 5 units of Botox. Again, 3 to 5 units for nasalis muscles in the upper face are typical doses for us. I've already talked about the lower face, 5 units of Dysport for DAOs, 10 units for platysmal bands. For the frontalis area, I'm typically using not much more than 10 units on people. I know there was some reports from some experts using up to 96 units in the upper face and making the forehead totally smooth. I just don't think that looks natural. The immobility of the brow is one of the big issues that people have. So 10 units for most people. If they have a high forehead, I might come up here and do a few little extension treatments and using maybe a total of 15 units. As I tell everybody, we want them to be able to move their forehead. We don't want their eyebrows to drop. Anybody that says that they can eliminate forehead lines, horizontal forehead lines with Botox and not affect brow position doesn't really understand the use of the product.